Hello, Dr. Ishak.
Hello.
Yes, please. Please, I think you can start.
Okay. All right. All right. So the topic this morning is Parkinson's disease. So any ideas what Parkinson's disease is? Anyone to tell us what Parkinson's disease is? Is anyone telling us or any ideas you have? Should I mention names or where is Dorcas?
Sir, please, I'm here.
Okay, so Dorcas, any ideas what Parkinson's disease is?
It's a progressive neurodegenerative condition that results from death of the dopamine cells.
Okay, that's good. So basically, when we say Parkinson's disease, the first thing you should know about Parkinson's disease is a neurodegenerative disease. Mm. So that's the first thing you should know about Parkinson's. It's a neurodegenerative disease. All right. And when we say neurodegenerative, it means that there is usually death of these neurons. And the death of these neurons usually come as a result of certain conditions. And one of the factors is age. So as you age, you have your neurons dying off. And some of these neurons are very vital in controlling movement. So if it's affecting the dopaminergic neurons, then you may have issues with your movement. So let's take note. It's a neurodegenerative disease. In fact, it's the second most common neurodegenerative disease in the world. It is the second most common neurodegenerative disease in the world. It just follows Alzheimer's disease. Alzheimer's is the number one. The number one cause of neurodegenerative disease in the world, followed by Parkinson's. I think in Ghana, we tend to see more cases of Parkinson's. I've not seen a case of Alzheimer's disease, but Parkinson's is quite common. So these are neurodegenerative disease, and they are usually associated with the elderly. So the elderly are usually prone to getting these neurodegenerative. As I said, as you age, your neurons die off, and some of the neurons may be vital in controlling movement, like the dopaminergic neurons. And you know, one of the role of dopamine in the body is dopamine controls the smooth and coordinated movement. So if you want to take something from the ground, it's the dopaminergic neurons that will aid in that. If you want to walk, all these are controlled by dopamine. So if you have issues with your dopamine, that smooth coordinated movement wouldn't be seen. So these are very vital neurotransmitters we have in the body. So if there's loss of dopaminergic neurons as a result of aging or other factors, then it can cause Parkinson's disease. All right. The next thing I want you to know about Parkinson's disease is in terms of the manifestations, it can present with motor and non-motor clinical manifestations. So it can present with motor and non-motor clinical manifestations. When we say motor refers to the movement of the limbs. So it may affect how you move your limbs, your hand, your legs, and all that. So these are the motor manifestations. The non-motor manifestations, any other symptom aside movement of the limbs. So it's not just about the movement of the limbs, but it can cause non-motor manifestations. Okay. So we want to look at certain key terms. So what's the difference between Parkinson's disease and Parkinsonism? If we hear of Parkinsonism and Parkinson's disease, what's the difference? Anyone to tell us? So Parkinson's disease, one of the things you have to know is it's largely idiopathic. The cause is unknown. So the exact etiology is not known. So we say it's largely idiopathic. However, it's been linked to certain influence, environmental influence and genetic influence. But the exact etiology is unknown. All right. Whereas when it comes to Parkinsonism is the presentation of Parkinson-like symptoms. And this is usually secondary to an underlying condition or some medication that you took. So maybe someone took metoclopramide. You know, metoclopramide is a dopamine antagonist. So it's counteracting the effect of dopamine. Dopamine controls your movement and all that. So if you counter the effect of dopamine, you can have some clinical manifestations that look like Parkinson's disease. But because we know the cause is you taking metoclopramide, we don't term it as Parkinson's disease because the underlying cause is known, which is a drug-induced. So we usually call it drug-induced Parkinsonism. If you know the underlying causes, patient took so and so medication and is presenting with these signs and symptoms, then we are talking about drug-induced Parkinsonism. Someone can also have a stroke. If you have a stroke and after the stroke event, you may have some motor symptoms, and these motor symptoms may present like Parkinson's disease. So all these are Parkinsonism because we know the underlying cause. If it's drugs, we know. If it's stroke, we know. If it's an infection, if it's trauma, all these are underlying causes. But Parkinson's disease, they are saying is idiopathic. The underlying cause is unknown. So if you do your exclusion, you exclude drugs, you exclude trauma, infection, stroke, and all that, and you are still not finding any underlying cause, then it's likely to be Parkinson's disease. Bearing in mind, usually this condition affects the elderly, 60 years and above. So if I see a 20-year-old presenting with Parkinson-like symptoms, I'll suspect an underlying cause, try to investigate. It's likely to be Parkinsonism. But if it's 60, 70-year-old, more likely to be Parkinson's disease if there is no underlying cause. Is it clear? Do you get the difference? Hello, can you hear me?
Yes, please.
Okay, all right. So that's the difference between Parkinson's disease and Parkinsonism. All right, so let's look at which part of the brain does Parkinson's disease affect? Anyone to tell us? Hello? Is anyone telling us which part of the brain does it affect?
The substantia nigra.
All right. So when you look at the brain, the basal ganglia, that is the main area Parkinson's disease affects. The basal ganglia is made up of certain structures. So one of them is what you mentioned, the substantia nigra. So I'll type them in the chat box so that you see the substantia nigra, the globus pallidus externa. So globus pallidus externa. Then we have globus pallidus interna. Then the subthalamic nuclei. The subthalamic nuclei. Then the striatum. The striatum is made up of the caudate and the putamen. Caudate and putamen. All right. So I've typed them in the chat box. So basically, what I'm saying is the part of the brain that is affected when you have Parkinson's disease is the basal ganglia. And this basal ganglia is made up of various parts or structures. So we have the substantia nigra, the globus pallidus interna, the globus pallidus externa, the subthalamic nuclei, the striatum. And the striatum is made up of the caudate and the putamen. When it comes to Parkinson's disease, the exact location which is affected is the substantia nigra of the basal ganglia. So you have dopaminergic neurons in the substantia nigra of the basal ganglia. So substantia stands for substance. Nigra, you know what nigra is. It comes from the word negro. So it stands for black. So that portion of the brain is dark. And it's because it's rich in pigmented dopaminergic neurons. So you have a lot of dopaminergic neurons within that place. So basically what we are saying is Parkinson's disease is loss of pigmented dopaminergic neurons in the substantia nigra of the basal ganglia. So when you have loss of pigmented dopaminergic neurons in the substantia nigra of the basal ganglia, then you can have Parkinson's disease. So that is the exact place which is affected. There are other conditions that may present with Parkinson-like symptoms may affect other parts of the basal ganglia. But when you talk about Parkinson's disease, the main place you are looking at is the substantia nigra. Is it clear? Okay. Let's move on to talk about some of the clinical presentation. So Parkinson's disease, I told you, can present with motor manifestations and also non-motor manifestations. So what are some of the motor manifestations of Parkinson's disease? Anyone to tell us some?
Hello.
Yeah.
Okay, so for the motor symptoms, could have the resting tremors, So that's usually just when the patient is at rest. Also, it's termed as the pill rolling tremors. We also have rigidity and bradykinesia.
Exactly. So what you mentioned is the three cardinal signs of Parkinson's disease. So the three cardinal signs of Parkinson's disease, these are motor manifestations. One of them is the tremors. And it's not just any type of tremors. We have action tremors, we have resting tremors. Action tremors occur during activity. So when you are doing something, that's when you see the tremors. Resting tremors, you see the tremors at rest. So when there is no activity, when you are at rest, that's when you start seeing the tremors. So the type of tremors that occur in Parkinson's disease is the resting tremors. So the tremors is seen only at rest. During activity, you wouldn't see the tremors. And this type of tremors characteristically is known as the resting or the pill rolling tremors. So the pill rolling tremors. So it's as if you are rolling a pill in between your fingers. You realize that the person is shaking, and the thumb, between the thumb and the index finger, is as if there is a pill there the person is rolling. So that's the characteristic type of tremors we see, the pill rolling tremors. Then you also mentioned bradykinesia. So bradykinesia stands for slow movement. Brady is slow. Bradycardia, slow. Kinesia, movement. So slow movement. So how the person walks is not the same, because now the person is having loss of dopamine in the substantia nigra, which is supposed to control movement. So the movement becomes slow. Then we could also have rigidity. So the muscles becomes very stiff. So there is rigidity. And this rigidity can present as two main types in Parkinson's. Who can tell me the two main types of rigidity you can have in Parkinson's?
So for the two types of rigidity, you could have the cup-filled, you have the lead pipe rigidity.
So you could have the cork-wheel rigidity or the lead pipe rigidity. Cork-wheel rigidity and the lead pipe rigidity. So I've typed them in the chat box. So basically for cork-wheel rigidity, usually affects the upper limbs. So cork-wheel usually would affect the upper limbs, so the hands, whereas the lead pipe rigidity usually affects the lower limbs. So at the bedside, if a doctor is suspecting a patient has Parkinson's disease, they clinically examine them to see whether the rigidity is a lead pipe rigidity or a cork-wheel rigidity. So the doctor tries to move the patient's arm through a range of motion. So it's like you are flexing your biceps. So if you are flexing your arm and you are relaxing it, you want to see whether there is any form of rigidity during that repetitive movement of flexing and causing relaxation of the arms. So if the doctor tries and he realizes that in between the movement or the motion, there's relaxation, intermittent relaxation, and also resistance, then we call it the cork-wheel. So cork-wheel rigidity is a ratchety pattern of rigidity where there's intermittent relaxation and resistance. So you have breaks during the range of motion. It's not rigid throughout. So there is some form of rigidity, then it slows down, you have breaks, then you have another rigidity, you have breaks again, then relaxation and all that. So that's how cogwheel manifests. So it's a ratchety pattern of rigidity characterized by resistance and relaxation through the range of motion. So that's how cogwheel presents. Whereas lead pipe rigidity, we said usually affect the lower limbs. And this type of rigidity is that the arms or the leg become stiff throughout the range of motion. So there are no breaks. So it's rigid throughout. But cogwheel, you have breaks in between the range of motion. So it's a pattern of relaxation and resistance. But lead pipe is just rigid throughout. There are no breaks for relaxation and all that. It's just rigid throughout. So that's the difference in the manifestation. Cogwheel, you have intermittent relaxation and resistance, whereas lead pipe is rigid throughout the range of motion. Okay. So if a patient has these three, we call it the three cardinal signs or the Parkinson's triad. So the Parkinson's triad, resting tremors, bradykinesia, and the rigidity. The fourth motor manifestation is postural instability. So aside tremors, rigidity, bradykinesia, you can have postural instability. And postural instability, there's imbalance in the gait. So there's imbalance in the gait or movements of the patient. So the patient is prone to falls. So there's imbalance in gait or movement, and as such, the patient is prone to falls. So that is one of the motor manifestation, but it's not part of the three main cardinal. It's the fourth motor manifestation you can have. Most patients wouldn't have it until the Parkinson's is very much advanced. But tremors, rigidity, bradykinesia, you can see it in the early manifestations. Any questions? All right, so let's look at some of the non-motor manifestations. Yeah,
Sir, please mention the name of the next one, the fourth one.
postural instability.
Thank you.
Okay, non-motor manifestations. What are some of the non-motor manifestations we can have?
So for the non-motor symptoms, could have slurred speech. Could also have anosmia, and that's the lack of smell. Blurred vision, dysphagia, sleeping disturbances, dementia, depression, erectile dysfunction.
Okay, all right, that's very good. So Parkinson's disease, you realize that the motor manifestation, you can have tremors, bradykinesia, rigidity. Imagine you are able to go about your everyday activity. You are able to go to work, do everything on your own. You can button up, you can lace your shoe. You can do everything on your own. Then all of a sudden you get Parkinson's disease. So you start having tremors. So because of tremors, it can take you like 30 minutes or 1 hour to button your shirt because of the lack of coordination and all that, you are unable to do that. If you are lacing your shoe, you are finding it difficult. You are not able to drive. You are not able to walk as you are supposed to do. So all these can affect your mental health. So one of the manifestations that Parkinson's disease patients would present with is depression. So you can become depressed all of a sudden. The things that you used to do, you can't do. You are just restricted. You are crossing the road and you are taking like 20 minutes to cross the road and people are horning on you and all that. So there's that kind of depression associated with the condition. is one of the non-motor manifestations. Then you can have anosmia, as he rightly mentioned, lack of smell. So you are not able to smell things. It can affect your ability to smell. Then you could also have micrographia. Micrographia, small handwriting. So very, very small handwriting, you wouldn't be able to see it. So micrographia can also be part. You could also have issues with your bowel movement and ability to urinate. So you can have urinary incontinence, fecal incontinence. You are not able to hold your urine. You are not able to hold your feces. So urinary incontinence, fecal incontinence. You could also present with constipation. So that slowness in movement can also affect peristaltic movement. So in terms of transit time, it can affect it. So you can have constipation also occurring. Then it may also affect your facial expression. Facial expression. So we have what we call hypomemia. Hypomemia. Type this in the chat box. Hypomemia. So this is called decreased facial expression. So the patient may have a decreased facial expression. You say something that you expect the person to laugh and the person is not laughing. It's not because the person doesn't find what you said funny or something, but it's because they have a decreased facial expression. So they are not able to express it on their face. It may take time, so it's slow, or it may not be expressed at all. So that's hypomemia. Then you could also have dementia. So it can affect how you recall some of the things that we see. So memory loss and all that. So you can have dementia. You could also have erectile dysfunction. So erectile dysfunction can also be present. So all these are non-motor manifestations. So your ability to swallow, dysphagia. So difficulty in swallowing can also be present. And imagine you're always having tremors at rest and it can affect your sleep. So you can have sleep disturbances. So you may have insomnia, which is very common because you are having all these motor manifestations, which is not allowing you to sleep. So it's very common in Parkinson's disease. So these are some of the non-motor manifestations you always want to find out in your patients. So the focus shouldn't just be tremors, rigidity, bradykinesia. If they have non-motor manifestation, you also want to address. If there is erectile dysfunction, you can address it. If there is constipation, you can address it. If there is insomnia, you can address it. So it's very important you take your history very well to be able to know some of these non-motor manifestations and also manage them accordingly. All right. So one of the earliest manifestation will be tremors. Most patients tend to present with tremors. So that's the first or earliest clinical manifestation you will most likely have. Then the others tend to follow. But there are other patients who even present with non-motor before the motor. So even before the tremors, the rigidity, bradykinesia, they may have issues with their sleep. So they may have issues with their sleep. They may be having constipation. They may be having depression or erectile dysfunction. All these may present even before the motor manifestation in some people. So these are some of the things that you should look out for. And because the signs and symptoms may be present in other conditions, you have to be careful to rule out drug-induced causes, to rule out any other condition that can present with tremors like stroke, trauma, infections, and all that, electrolyte imbalance. You want to rule all these things out before you say, if you have this, if you have that, then you are likely to have Parkinson's. Any questions before we move to the diagnosis? All right, so let's talk about the diagnosis. So the diagnosis is very simple. Diagnosis, as usual, you start with the history. So you want to find out when all these started, which signs and symptoms do they have? Is it tremors? Is it rigidity? Is it bradykinesia? Do they have constipation, dementia, depression, and all? So these are the signs and symptoms you want to look out for. Then you also want to rule out drug-induced causes. So you want to find out, have you not taken any medications like metoclopramide? Antipsychotics. Antipsychotics can also present with Parkinson-like symptoms. So you want to rule out any drug-induced cause. Then you also want to look out for other conditions that may present with Parkinson's disease. So if you are thinking of traumatic brain injury, stroke, then you want to do a CT or MRI. So if you suspect maybe the patient is telling you this tremors is sudden onset, it started maybe after they hit their head on something in an RT, or maybe they fell down traumatic, or it was just all of a sudden and it started. You want to rule out any other conditions like stroke, traumatic brain injury, so CT or MRI. So these are not routine tests that we do to diagnose Parkinson, but we do it to rule out other conditions. So stroke, traumatic brain injury, you can do CT or MRI. Then at the bedside, clinical examination. So this is where the doctor tries to see, do you have rigidity? So he tries to move your arms through the range of motion to see whether there's coccygeal rigidity or whether there's lead pipe rigidity. Then he also wants to find out whether there's tremors or bradykinesia. So these are clinical examination. One other clinical examination that can be done is known as the glabella tap test. So glabella tap test. So I've typed it in the chat box. Glabella tap. All right. So the space between your two eyes. So you know the two eyes. There's a space between your two eyes. That area is known as the glabella. And this glabella area, for someone who is normal, if you constantly or repetitively tap the glabella area, the person will then have involuntary movements of the eyes. So for a normal patient, if you continuously tap the glabella area, there wouldn't be any involuntary movements of the eyes. But for a Parkinson's disease patient, the moment you start to tap the glabella area with your finger, you realize that you have this involuntary movement of the eyelids. So they are not controlling it. It's an involuntary movement of the eyelids. And this is because you are tapping the glabella area. Once you have that, then it's a positive glabella test for Parkinson's disease. So there's a bedside examination you can easily do. You just tap the patient's glabella area to see whether there will be involuntary movement of the eyelids or not. If there is no involuntary movement, then it's unlikely to be Parkinson's disease. But if there is involuntary movement of the eyelids, because you are continuously tapping the glabellar area, then the patient likely has Parkinson's disease. Other than that, you wouldn't need any special investigation for Parkinson's disease. So the diagnosis is clinical. So when we say diagnosis is clinical, it means that you just need your history and clinical examination, the signs and symptoms to confirm your diagnosis. You don't need any special investigation, laboratory investigation. You don't need that. So in terms of the diagnosis, if you have 2 out of the 3 cardinal signs of Parkinson's disease, it's enough to diagnose the condition. If you have 2 out of the 3 cardinal signs of Parkinson's disease, then we can say the person has Parkinson's. Remember the 3 cardinal signs: the resting tremors, bradykinesia, rigidity. So if you have 2, maybe the patient has resting tremors, also has bradykinesia, but doesn't have rigidity. The patient has Parkinson's disease if we've excluded other conditions that may present as such. So if we've excluded stroke, traumatic brain injury, infections, electrolyte imbalance, drug-induced causes, and you realize the patient has 2 out of the 3, so resting tremors, bradykinesia, then the patient has Parkinson's. Another patient may present with bradykinesia and also rigidity without tremors. The patient also has Parkinson's. If you have bradykinesia or just tremors with rigidity, there's also Parkinson's if you've excluded other conditions. So it's very simple to diagnose. 2 out of the 3 cardinal signs plus your other manifestations. So you want to find out non-motor manifestations if they are present. If you've ruled out other conditions, stroke, traumatic brain injury, infections, electrolyte imbalance, drug-induced causes, then you are dealing with an idiopathic case, so Parkinson's disease. If you know of drug-induced causes, you know of any underlying electrolyte imbalance, stroke, then that becomes Parkinsonism. But if there is no other condition presenting as such, then it's Parkinson's disease, 2 out of 3 cardinal signs. Is it clear? Any questions? All right, so let's look at the management. So for the management, the key management strategies, we have 3 main management strategies when it comes to Parkinson's disease. So the first one is your pharmacotherapy or medical therapy. Your pharmacotherapy. Then you could also have surgical intervention. Then as usual, the other non-pharmacological therapies you can also do. So the 3 main strategies are, the first one I didn't talk about, but the first one is when the signs and symptoms start, you may do a watchful waiting. You may not start your treatment. Then there's option to do pharmacotherapy if the signs and symptoms become very worse. Then there's also option to do the surgery. But the main management is the pharmacotherapy. The other ones are not usually part of the main management. You can do it for certain patients. If your symptoms are not worse, we may not put you on medications. If it becomes worse, then you start the medication. The surgical intervention is also usually not used. So the focus will be on the pharmacotherapy. So for pharmacotherapy, most of these drugs aim is to increase the level of dopamine. Parkinson's disease, we said the issue is loss of dopaminergic neurons in the substantia nigra. And that is why we are having all these signs and symptoms. So anything that will increase the levels of dopamine in the brain would help increase or will help regulate the movement. And there are a lot of classes of drugs we can use. So what are some of the classes of drugs that can be used for the management? Anyone to help us with some of the classes?
Sir, please, we have the dopamine precursors.
Yeah, so the dopamine precursors. So you can have levodopa combined with carbidopa or levodopa combined with benserazide. So these are levodopa-based combinations. So levodopa with carbidopa. So levodopa with carbidopa. I've typed it in the chat box so you can see. So levodopa with carbidopa and levodopa with benserazide. So these are levodopa-based combinations. Okay, what again?
Okay, we can also have the monoamine oxidase B inhibitors.
Yeah, so the monoamine oxidase B inhibitors. So monoamine oxidase B inhibitors. Any other?
Sir, please, we can have the dopamine agonists.
Yeah, dopamine agonists. Any other?
You can have the catechol or metal transferase inhibitors.
Yeah, so catechol O metal transferase inhibitors. So catechol O metal transferase inhibitors. These are the COMT inhibitors. Okay, any other?
Anticholinergics.
Anticholinergics. Anticholinergics. Okay. Any other?
Sir, please, the dopamine decarboxylase inhibitors.
I didn't hear what you said.
Sir, please, dopamine decarboxylase inhibitors.
Okay, so that would be part of the levodopa carbidopa or levodopa benserazide. That would be that for so the levodopa based combinations. Okay. We could also have apomorphine.
You have the dopamine agonist too.
Yeah, so the dopamine agonist. Okay. Any other? All right, so let's look at the various classes. So we've talked about the levodopa based combinations, where you can have levodopa carbidopa, levodopa benserazide, then the monoamine oxidase B inhibitors, the catechol O methyl transferase inhibitors. You could also have the dopamine agonists. You could also have catechol O methyl transferase inhibitors, then anticholinergics, apomorphine. The last one we didn't talk about, antivirals. Antivirals. So here we have amantadine. So amantadine. All right. So let's look at the various classes of medications we can use. During the introduction, we said Parkinson's disease is loss of dopaminergic neurons in the substantia nigra. So the issue is you don't have enough levels of dopamine in the substantia nigra to coordinate our movement. So if you want to control and coordinate our movement, what we need is dopamine, right? And we have dopamine injections available. So why are we not giving dopamine injection to treat Parkinson's disease? Because I didn't see that when we were listing the classes of drugs we can use. Any reason why we don't use dopamine?
Hello, Dr. Ishak.
Yeah.
Look, I believe dopamine alone cannot cross the brain blood barrier. So for that matter, if it is not be able to help, that's why we don't use the alone.
You are getting some feedback.
Sorry.
All right, so for Parkinson's disease, the main issue is we don't have enough levels of dopamine. But that doesn't mean that we can give dopamine to treat Parkinson's disease. Parkinson's or dopamine does not cross the BBB. When you give dopamine, dopamine will stay within the periphery. It wouldn't be able to cross the BBB and get into the substantia nigra. So what it means is that you just have the dopamine in the periphery. You may have the side effects. And what we really need in Parkinson's disease is the dopamine should get into the brain. But you wouldn't have that because dopamine does not cross the BBB. So for this reason, we formulate dopamine in another form. And this form is supposed to enable the dopamine cross the BBB. So this is where levodopa-based combination comes. So levodopa is a prodrug. So it's a prodrug which is converted to dopamine. And we are formulating dopamine in the form of levodopa because levodopa can easily cross the BBB. So that is the main reason why we have dopamine formulated in the form of levodopa. So levodopa can easily cross the BBB. And when it crosses the BBB and gets into the brain, that levodopa will be converted back to dopamine because dopamine is what we need. So levodopa will be able to cross. When it gets into the brain, it will be converted to dopamine, and dopamine is what we need in Parkinson's. Now, the conversion of levodopa to dopamine is done by an enzyme known as dopa decarboxylase. So the dopa decarboxylase enzyme is what is going to convert levodopa to dopamine. And this dopa decarboxylase enzyme, we have some in the periphery and we also have some central. So there's some in the brain and some in the periphery. So the conversion of levodopa to dopamine is done by the dopa decarboxylase. And we are saying this enzyme can be found both in the central and also in the periphery. So let me ask you, if you give the levodopa alone, since we have the dopa decarboxylase in the periphery, wouldn't it be converted from levodopa to dopamine in the periphery? Because if you get dopamine in the periphery, it can be able to cross. So what can you do to avert this? So what can you do to prevent the levodopa from being converted to dopamine in the periphery?
So you add carbidopa.
Yeah, so under no circumstance should you give levodopa alone. If you give levodopa alone, what it means is that the dopa decarboxylase in the periphery will convert it to dopamine. So if you form dopamine in the periphery, that dopamine cannot cross the BBB. And we need dopamine in the brain, so it has to get into the brain. So if the conversion is done in the periphery, then dopamine cannot cross. We are formulating it in the form of levodopa so that levodopa can cross. When it gets into the brain, it will be converted to dopamine. So to prevent this, we add another agent to levodopa in the form of carbidopa or benserazide. So you can add carbidopa or benserazide. And the purpose of this second medication is to inhibit peripheral conversion of levodopa to dopamine. So these carbidopa benserazide inhibit the dopa decarboxylase enzyme at the periphery. And by doing so, it prevents the conversion of levodopa to dopamine in the periphery. The carbidopa and benserazide have no effect on the dopa decarboxylase in the brain. So they are selective for the dopa decarboxylase in the periphery, not for the brain. So if they inhibit the conversion of levodopa to dopamine in the periphery, when levodopa gets into the brain, the dopa decarboxylase there now converts levodopa to dopamine. And that is how we can get our dopamine in the brain. Is it clear?
Yes, please, sir.
Okay. So that is just one reason for combining levodopa and carbidopa. Any other reason for the combination?
So because there's no conversion in the periphery, carbidopa allows you to give a small amount since everything will get into the brain.
Exactly so. So by the combination, it allows you to give a smaller dose of the levodopa. So if you give, so let's use quantitative analysis. So ideally, let's say you need 100 milligrams of levodopa in the brain. If you give 100 milligrams of levodopa alone, you realize that because there is dopa decarboxylase in the periphery, 50 milligrams will be converted and 50 will get into the brain. So you have 50 milligrams being converted in the periphery, then 50 getting into the brain. So you are not getting your 100. So to be able to get the 100 in the brain, you may have to increase the dose to maybe 150. So that if it's 150, you know that 50 will be converted in the periphery and 100 will get into the brain. However, if you combine levodopa with carbidopa, you know that if you give 100 milligrams of levodopa, we are very sure that that 100 milligrams will get into the brain because the dopa decarboxylase in the periphery has been inhibited. So there's no conversion in the periphery. So you are sure that 100 milligrams will get into the brain. So if I do the combination, I just need 100 milligrams to get into the brain. But if I'm giving it alone, then that means I will need 150 because I know that 50 will be converted in the periphery and 100 will get into the brain. So by this combination, it allows you to give a lower dose of the levodopa compared to just doing it alone. Okay. Any other reason why we do the combination?
So another reason is also to have minimal side effects, such as the nausea, vomiting, and hypertension.
Exactly so. So the combination reduces the side effects of levodopa. The side effects of the levodopa are usually because of the conversion of levodopa to dopamine in the periphery. So the more you have dopamine being converted in the periphery, the more you have the side effects. So the combination allows you to have a reduced side effect from the levodopa. And the common ones is the nausea, the vomiting, and orthostatic hypotension. So these are usually the common side effects. So when you do the combination, you have less risk of nausea, vomiting, and orthostatic hypotension. So that is the third reason for the combination. So the first one prevents peripheral conversion of levodopa to dopamine. Then it also allows you to give a reduced dose of the levodopa, and it also reduces the side effect associated with levodopa. All right. So the typical dosing, what's the typical dosing we do for Parkinson's disease if we want to do levodopa, carbidopa? How do you give it? Well, we have available strength on the market. So the available strength, we have 2,500. If we see 2,500, it means that 25 of carbidopa, 100 of levodopa. You could also see 50-200. That means 50 of carbidopa, 200 of levodopa, or 50, 12.5, and all that. So these are some of the available strengths. So if we are trying to start the patient on this combination, the frequency of dosing is important. So if you see 2,500 Sinemate, you should know some of the common brand names. So levodopa, carbidopa, the common brand name is Sinemate. Whereas levodopa, benzarazide, common brand name is Madopa. So Madopa and Sinemate. So if you see Sinemate 2,500 daily, would you be concerned or it's okay? Any ideas? 25 milligram / 100 milligram once a day of Sinemate. Are you okay with this?
So please, can you kindly go over the strengths again?
So 25 milligram, 100. So 25 of carbidopa, 100 of levodopa once a day. So if you see this, it's not appropriate because in a day, if you really want to effectively inhibit dopa decarboxylase, the amount of carbidopa you should give in a day should be within the range of 70 to 100 milligram per day. So if you do 125 daily, what it means is that the whole day you're giving 25 milligram of carbidopa, which is not enough to effectively inhibit the peripheral dopa decarboxylase. So if you want to effectively inhibit the dopa decarboxylase, you need 70 to 100 milligram of carbidopa a day. So you should be looking at doing TDS. So Sinemet 25 milligram / 100 milligram TDS. That would mean that in a day you are giving 75 milligram of the carbidopa, and that falls within the 70 to 100. So to effectively inhibit peripheral dopa decarboxylase, you need 70 to 100 milligram carbidopa in a day to do that. All right. The other things that you also want to tell the patient, common counseling point, is to avoid taking high protein diet. So high protein diets usually contain, digestion of protein. The end product of protein digestion is amino acids. These amino acids tend to compete with levodopa for GI absorption. They use the same transporter. So the transporter for amino acid absorption is also the same transporter for levodopa. So you avoid taking high protein diets whilst taking levodopa because of competition between amino acids and levodopa for GI absorption. So you can take it with meals, all right, before meals, but you should make sure that whichever meal you are taking shouldn't be high protein diet. And the other counseling points, common one you also want to tell them is levodopa, carbidopa can cause urine discoloration. So when they see their urine changing to brown and all that, they shouldn't be concerned because it's from the drug. So you can have urine discoloration from the drug. So they shouldn't be alarmed whenever they see that. Okay. Any questions?
Hello, sir.
Yeah.
Good morning. Please,
Good
my
morning.
question is with the dosing, with the side effects, with a combination. And you said that the maximum dose for carbidopa is 70 to 75 milligrams. So with the combination, are you not going to have a higher concentration of the levodopa, or it's okay?
What I was saying is the dose range, which is enough to inhibit peripheral dopa decarboxylase, is that you need the carbidopa component to be within 70 to 100 milligram a day. So the carbidopa component of Sinemet 125 is the 25 milligram. So if you are doing 25 milligram daily, then it's less because you need the range of carbidopa in a day to be 70 to 100. So if you are doing 25 daily, it's less. If you are doing 125 BD, it's still less. So if you do TDS, then it's within the range of 70 to 100 milligram a day. I didn't say you need the total dose to be between that, but it's only the carbidopa component, which should be between 70 to 100.
Okay, thank you.
Okay. Any other question?
Hello.
Yeah.
Yeah, so what I think the other lady was asking is, wouldn't that, because they come in a combination, wouldn't that also increase the dose of the levodopa to like 300? Is that okay?
Yeah. Because that's the usual treatment dose. So it's not the 100 milligram levodopa has a very short half-life. So the 100 milligram doesn't cater for a 24-hour. So maybe the morning symptoms, the tremors, rigidity, right, body kinesia will be ready. But afternoon, evening, the patient will have very severe symptoms. So you need multiple dosing of the levodopa. So for the levodopa, you can give as much as the patient can tolerate. Just that what we are concerned about is we want to prevent the conversion of levodopa to dopamine in the periphery. So if that conversion happens, then you are going to have side effects of the levodopa. So you need the carbidopa component within that range. So if I'm doing the strength, which is 250, the 250, I can decide to do BD. So 250, that BD means I have 100 milligram of carbidopa within a day. Is it clear?
Hello. Yes. I wanted to ask another one.
Okay.
Please, you mentioned two brands, the Sinemet and please, which other one?
Madopa. So Madopa is the brand name for levodopa benzarazide. The Sinemet is the brand name for levodopa carbidopa. So sometimes they ask questions. So if we have a case study and they say Sinemet, and you don't know what Sinemet is, you find yourself wanting, because Sinemet is the brand name for levodopa carbidopa. So the subsequent questions you may not be able to, but you should know common brand names. So Sinemet, levodopa carbidopa. Madopa is levodopa benzarazide. Any other question?
Do they also come in the same strength?
Yeah. So if you see 125 of Madopa, it's 25 of benzarazide, 100 of levodopa. Okay. Let's talk about the other classes of the medications. So aside the usual side effects that I've talked about, there's usually these motor dyskinesias associated with levodopa. So even though we are giving levodopa to treat these motor manifestations, but levodopa has its own issue. So if you use it for a very long time, you may develop some motor dyskinesias. So another motor complications associated with levodopa. So when you start having these motor dyskinesias, then you may need other agents to be adjunct to the levodopa-based combinations. All right, so let's look at the other agents that we can use. So we've talked about levodopa, carbidopa, levodopa benzarazide. The other class of drugs is dopamine agonists. So for dopamine agonists, basically these are drugs that are supposed to activate the dopamine receptors. So if you activate dopamine receptors, it's as if it's dopamine that is actually doing the activation. So they act like dopamine. They are agonists on the dopamine receptors in the substantia nigra. And the dopamine agonists are subdivided into two. So we have what we call the ergot-derived dopamine agonists and the non-ergot-derived dopamine agonists. So ergot-derived and non-ergot-derived. So you know the ergot plant, so the ergot alkaloids. So the ones that we get from the ergot alkaloids are known as the ergot-derived, and the ones that are not from the ergot alkaloid are the non-ergot derived. So what are some of the examples under ergot derived and non-ergot? So let's start with the ergot derived. Examples under ergot derived. So under ergot derived, we have bromocriptine. So bromocriptine and also cabergoline. So bromocriptine and cabergoline. These are ergot derived. And the non-ergot derived example is pramipexole. So pramipexole, ropinirole. So I've typed them in the chat box so that I see. So pramipexole, ropinirole, then rotigotine. So these are the examples under dopamine agonists. So the ergot-derived ones are the bromocriptine and cabergoline. And the non-ergot-derived pramipexole, ropinirole, rotigotine. All right, so as I said, these agents are acting like dopamine on these receptors. So for the ergot-derived bromocriptine, cabergoline, they are not usually used in Parkinson's disease because of their side effect. They are usually associated with cardiac and valvular issues. So you can have cardiac and valvular issues with the ergot derived. So because of that, they are usually not used. So you can have cardiac or valvular fibrosis. So because of that, we don't usually use bromocriptine and cabergoline. It may find use in other conditions, usually hyperprolactinemia. So if you have a woman and maybe they went for delivery and they lost the baby in the process, because the body was preparing for a baby, he had high levels of prolactin. And because of that, there will be breast milk production. To prevent or to reduce this breast milk production, you need these agents, cabergoline or bromocriptine. These are supposed to act as dopamine agonists. Dopamine has a relation with prolactin. So dopamine inhibits prolactin. So these act like dopamine. They are dopamine agonists. So they act on the receptor to inhibit the levels of prolactin. So the prolactin levels decrease. Then the breast milk production also decrease. So this is where these agents find their use, hyperprolactinemia. And that one, just 1 or 2 doses is enough to control the hyperprolactinemia. So it's not something you take long term. But in Parkinson's disease, these medications would have to be used long term. And because of that, the high risk of cardiac and valvular fibrosis. So we usually don't use them. So the preference is the non-ergot derived. So the non-ergot derived, I said pramipexole, ropinirole, rotigotine. These are the agents we usually use in Parkinson's disease. So for the non-ergot derived, they are usually used in patients who are having motor dyskinesias from levodopa. So if you are on levodopa and you're having these abnormal movements, then we can fall on dopamine agonist. They are usually associated with another form of side effect we call impulse control disorders. So impulse control disorders. So unlike the levodopa base, they are associated with motor dyskinesias. But when it comes to the dopamine agonists, their main side effect is impulse control disorders. And these impulse control disorders are obsessive compulsive disorders. So let's take a scenario where this person doesn't like betting. It's not the betting type. He doesn't gamble and all that. Then all of a sudden you started the patient on the medication. And after some time, this person is always gambling, he's always betting, he's always hypersexual. So there's hypersexuality. He always wants to have sex. There's pathological shopping. So everything they see, they want to buy. Even things they don't need, they want to buy. So impulse control disorders is an obsessive compulsive disorder which is associated with pathological gambling, pathological hypersexuality, and pathological shopping. So you put the patient on the medication and all of a sudden, everything they see, they want to buy. They are always hypersexual. They are always gambling. Then you know that the person has impulse control disorder. And this is usually associated with the dopamine agonist. So pramipexole, rotigotine, ropinirole, they tend to cause impulse control disorders. All right. In terms of preparation. Okay. That's your question.
Please, so the levodopa causes the motor dyskinesia, and we want to use the ergots to treat it. Do you stop the levodopa or you use it?
I'm struggling to hear your question. Hello. Hello. Can't hear your question.
Hello, please, can you hear me now?
Yeah, I think it's better.
Please, I was asking that. So when you are using the non-ergot derived agonist to treat the motor dyskinesia that has been caused by the levodopa, do you have to stop the levodopa?
No, you don't stop the levodopa. The patient will be on it, but you need adjuncts to control the signs and symptoms. So you may just reduce the dose of the levodopa, then add another agent, but you don't stop.
Thank you.
Okay.
As I have a question too. I want to know how long is long for you to start initiating these other agents in addition to the levodopa based.
Is that how long?
Yeah, how long? You said after, due to the side effects that the levodopa based combinations come with. So I want to know when you start initiating these dopamine agonists in addition to the levodopa based combinations.
Yeah, so it's not always the case that you should start levodopa first before dopamine agonist. For some patients who are at high risk of these motor dyskinesias, you can just start the other agents. So some patients will just start with anticholinergics. Other patients will come, we just start with monoamine oxidase inhibitors, or we just start with dopamine agonist. Just that the preferred first line is levodopa based combination. Usually, people who are young, presenting with Parkinson's disease, so if you are less than 50 years, 60 years, presenting with Parkinson's disease, we see it to be a young age. So for these patients, it's been shown that they are at a high risk of getting these dyskinesias because they are young. If you start levodopa early, when they start it for some time, they start to have the wearing effects of the levodopa. The dyskinesias start to set in. But if they are old and they start levodopa-based combination, then it's better for them because the time that they will start getting the dyskinesia, they may be heading around the 80s, 90s. So it's better for you to start dopamine agonist if the person is young. So for young populations, less than 60 years presenting with Parkinson's, you may want to start dopamine agonist because it's associated with less motor fluctuations. But the old populations, they tend to have better control. So for them, you can start with the levodopa, carbidopa.
Okay, thank you.
Okay. So we're talking about the impulse control disorder. So you can have pathological gambling, pathological hypersexuality, then also pathological shopping. All right. For the
Sir, please, dopamine agonist. If you have a patient where their dopaminergic receptors, the reserve there is very little, how effective will it be in such patients?
you'll never know until you start. So if you start and the patient is not responding, then you know that maybe there's something wrong. So you may have to go to the preferred first line, which is levodopa and carbidopa. Unless you start, you wouldn't know.
Okay, thank you.
Okay. So I was talking about the available preparation. So pramipexole, ropinirole, rotigotine. So in terms of the formulation, pramipexole and ropinirole are available as oral medications. So you have tablets for ropinirole and pramipexole. But rotigotine comes in the form of a transdermal patch. So rotigotine is in the form of transdermal patch that you can place on the skin. But pramipexole, ropinirole are oral medications. And aside the impulse control disorders, they may also be associated with somnolence. So you tend to have a lot of daytime sleeping and all that associated with the dopamine agonist. So there's somnolence. You may have nausea and vomiting. You may also have hallucinations. So these are some of the common side effects aside the impulse control disorders. So somnolence, daytime sleeping, nausea, vomiting, hallucinations. All right. Let's look at the next class of anti-Parkinsonian. So we also have the catechol or methyltransferase inhibitors. So the catechol or methyltransferase inhibitors. So these are the COMT inhibitors. These agents are not used as a standalone. So they are used as adjuncts to the main therapy. So basically what they do is they inhibit the enzyme catechol or methyltransferase. This enzyme also breaks down the dopamine. So it also breaks down dopamine. So you want to prevent the conversion of levodopa to dopamine with your dopa decarboxylase inhibitors. Aside that, there are also other enzymes that can break down the levodopa. And one of them is catechol O methyltransferase. So catechol O methyltransferase inhibitors are there to prevent the conversion of levodopa to another molecule known as 3-O-methyl-dopa. So levodopa is converted to 3-O methyl dopa by the COMT, which is catechol or methyl transferase. So we want to give COMT inhibitors to prevent levodopa from being converted to 3-O-methyl transferase. And the COMT, you have some of the COMT enzyme in the brain. There's also COMT enzyme in the periphery. So for patients who are not responding to levodopa carbidopa, we can add a COMT inhibitor. So the COMT inhibitor, I told you, they are used as adjuncts. They are not used as a standalone. So we have examples of the COMT inhibitors as entacapone, tolcapone, or opicapone. So I'll type them in the chat box. So entacapone, tolcapone, then opicapone. So these are COMT inhibitors. So you can have a combination like levodopa, carbidopa, and entacapone. And this is common on the markets. The common brand name is Stalevo. So Stalevo is a combination of levodopa, carbidopa, and entacapone. In this combination, as I said, the carbidopa prevents conversion of levodopa to dopamine by inhibiting dopa decarboxylase. There's also entacapone to also prevent the conversion of levodopa to 3-O-methyl 3-O-methyl dopa by inhibiting the catechol O-methyl transferase enzyme. So all that we are trying to do is we want to increase the level of levodopa that will get into the brain. So the peripheral COMT is inhibited. The peripheral dopa decarboxylase is also inhibited. Once it gets into the brain, you can have the conversion of levodopa to dopamine. And this is what we want because we need more dopamine in the brain, not the periphery. So anything that will convert levodopa in the periphery, we want to inhibit. So dopa decarboxylase and also the catechol or methyl transferase. So they are not used as a standalone, they are used as adjuncts. All right. So for these agents, one of the common side effects is they tend to cause urine. Hello.
You seem to be going too fast.
So which
But I
part
have some
didn't you
questions.
get?
So please, you said the combination, the brand name is what?
I've typed it in the chat box, Stalevo.
And I couldn't also get the mechanism of action very well. I heard you said it inhibits.
They are COMT inhibitors. They inhibit catechol or methyl transferase. This enzyme is responsible for conversion of levodopa to 3-O-methyl dopa. So if you inhibit the COMT, which is catechol or methyl transferase, in effect, you are preventing this conversion. And that allows you to have enough levels of levodopa to cross the BBB. Because we need levodopa not to be converted in the periphery. So if we've inhibited dopa decarboxylase, there's also another enzyme that can break down levodopa in the periphery, which is the COMT. So we want to inhibit the COMT in the periphery so that when the levodopa crosses the BBB and gets into the brain, can be converted to dopamine in the brain. So that's the purpose of the COMT inhibitors. They are not used as a standalone, as I said. They are used as adjuncts to the main therapy, which is levodopa and carbidopa. So if the person is not responding to levodopa, carbidopa, you can switch to Stalevo. And Stalevo is levodopa, carbidopa, and entacapone. Any questions? All right. So I was talking about the common side effects that you have. So entacapone is usually used compared to the other ones. Tolcapone is the most effective COMT inhibitor. So it's the most effective COMT inhibitor, but it's associated with severe hepatotoxicity. So because of that, we usually do not use tolcapone, even though it's the most effective COMT inhibitor, but it's associated with hepatotoxicity. So we tend not to use the tolcapone. And the other side effect is they tend to cause urine discoloration. So they can cause urine discoloration, usually orange discoloration of urine, brownish discoloration of urine. You always have to advise the patient so that they do not become alarmed if they see this orange or brownish discoloration of the urine because of these agents. All of them cause urine discoloration except opicapone. So entacapone can cause urine discoloration, tolcapone can cause, but opicapone does not cause urine discoloration. Okay, so that's for the COMT inhibitors. Any questions? Okay, so
If
let's
I
look
got
at the
you,
some.
yeah. If I got you right, you said that is the tolcapone that's associated with the hepatotoxicity, and for the two, entacapone and tolcapone, they have the brownish discoloration of urine. Please, did you mention just these two side effects?
Yeah, so these two are the things that are common.
Right, thank you.
Okay. Any other question? All right, so let's look at the monoamine oxidase B inhibitors. So monoamine oxidase B inhibitors. So for the monoamine enzyme, we have monoamine oxidase A and monoamine oxidase B. So these agents are selective monoamine oxidase B. They have no effect on the A. There are other classes of drugs that will do both A and B. So those are non-selective monoamine oxidase inhibitors. So the non-selective ones will inhibit both A and B. But the agents we use in Parkinson's disease are the selective monoamine oxidase B inhibitors. And basically, the monoamine enzyme is responsible for breakdown of catecholamines. So we have catecholamines in the body like noradrenaline, serotonin, dopamine. All these are broken down by monoamine oxidase enzyme. So this enzyme is responsible for their metabolism. So the purpose of the monoamine oxidase B inhibitors is to inhibit the breakdown of dopamine, because dopamine is one of the catecholamines that is broken down by monoamine oxidase enzyme. So if it prevents the breakdown of catecholamines by inhibiting monoamine oxidase B, what it means is dopamine is going to accumulate, and that is going to help with our movement. So we need more dopamine, and we need to inhibit the enzyme that breaks down dopamine so that we have more levels of dopamine available. So that's the rationale for these agents. Examples under this class. We have selegiline, which is common, and we also have rasagiline. So selegiline and rasagiline. The third one is not common, which is sulfonamide. So selegiline, I've typed it in the chat box so that you see selegiline, rasagiline, and sulfonamide. All right, so these are the examples of the selective monoamine oxidase B inhibitors we have. And these are also not used as the main therapy. So they are usually used as adjunct to the main therapy, unless some few people who we may start selective monoamine if they are prone to getting the side effects. Selective monoamine oxidase B inhibitors is very tolerable. So in terms of side effects, it's better to tolerate monoamine oxidase B compared to starting levodopa, carbidopa. So some patients, we may start them on monoamine oxidase B, and when the symptoms becomes worse, then we introduce the levodopa and the carbidopa. So those who are prone to the motor dyskinesias, young people, you may want to start with selective monoamine oxidase B. In the example, selegiline is readily available. The rasagiline, sulfonamide are not readily available. The issue with these agents is that, so for example, selegiline, if a doctor prescribes selegiline 5 milligram BD, you know BD means every 12 hours. So if it's 5 milligram BD, then that means the patient should take it at 6 a.m. or 6 p.m. So 6 a.m. and 6 p.m. or 7 a.m., 7 p.m., 12 hours apart. That's the usual thing we know when it comes to BD. But if you get a prescription of selegiline 5 milligram BD, you don't have to tell the patient to take it 7 a.m., 7 p.m. This is because of the risk of severe insomnia. So if you take it at night, you wouldn't be able to sleep. So the recommendation is, if you get a twice daily dosing of selegiline, you take the first dose in the morning, so around 6 a.m. Then the second dose, you can take it around 12 noon or 1 p.m. You can take it around the lunch time, so 12 noon, 1 p.m. But you shouldn't take it around 6 p.m., 7 p.m. because of the risk of insomnia. What happens is selegiline is broken down to amphetamine metabolites. So the breakdown products of selegiline is amphetamine. And you know amphetamine is a CNS stimulant. So it keeps you awake. So you are not able to sleep at night. So that's the issues with selegiline. So you always want to advise the patient twice daily dosing, take it around 6 a.m. The second dose, take it around lunchtime, around 12 or 1. All right. Because the catecholamines are not just dopamine, you know, we have serotonin and all that. So these agents may also be associated with serotonin syndrome, especially if you combine it with other agents that increase the levels of serotonin. So SSRIs, if you combine with SSRIs, the risk of serotonin syndrome is high. All right. So for these medications, would you advise the patient to take it with red wine, smoked meat, cheese, and all that? Would you recommend the patient takes it with these foods I've mentioned? Any ideas? Right. So the foods that I mentioned, red wine, cheese, smoked meat, and all that, they tend to contain high levels of a compound known as tyramine. So tyramine is high. So these are what we call tyramine-rich foods. So usually you don't combine these tyramine-rich foods with non-selective monoamine oxidase inhibitors. So the non-selective ones inhibit both A and B. Monoamine oxidase A breaks down tyramine. So for tyramine, which we are saying is high in red wine, cheese, smoked meat, and all that, because they tend to have high levels of tyramine, you need monoamine oxidase A intact to break down the tyramine. Because if you don't break down the tyramine would accumulate. And once you have high levels of tyramine, it can precipitate hypertensive crisis. And this is what we call the cheese reaction. So the cheese reaction usually occurs when you take non-selective monoamine oxidase B inhibitors with tyramine-rich foods like red wine, cheese, smoked meat, and all that. So because you've taken it with tyramine-rich foods and you are also on monoamine oxidase inhibitor, the non-selective one, the monoamine oxidase A, which is responsible for breaking down tyramine, has also been inhibited by the drug. So tyramine tends to accumulate. And once you have high levels of tyramine, it can precipitate hypertensive crisis to cause the cheese reaction. But you don't see this with the selective monoamine oxidase B inhibitors, the salicylic rasagiline, because their effect is not on monoamine oxidase A. So they only inhibit monoamine oxidase B. So if you take red wine, you take cheese with these agents, the monoamine oxidase A is still intact to metabolize the tyramine. So you wouldn't have that effect. At the normal therapeutic doses, at very high doses of maybe salicylic rasagiline, it loses that selectivity for monoamine oxidase B. It can inhibit monoamine oxidase A. For which reason, if you combine it with red wine or any of these tyramine-rich foods, you can have cheese reaction also with these agents. But at the normal therapeutic dose for Parkinson's, you shouldn't see any cheese reaction with these agents. Is it clear?
So please, did you say at high doses it loses its selectivity?
Yeah, so
Hello,
at high
Dr.
doses of salicylic or rasagiline, it loses the selectivity for the monoamine oxidase B. It may inhibit monoamine oxidase A. And you know monoamine oxidase A breaks down tyramine. So once you have that and you combine it with cheese, red wine, smoked meat, then you can have the cheese reaction. But the normal therapeutic dose for Parkinson's disease, you shouldn't have cheese reaction with salicylic.
Hello, Dr.
Hello?
Hello.
Yeah, go ahead.
Please, can you go over the cheese reaction? I was saying, can you go over the cheese reaction?
So I'm saying that there are certain foods that contain high levels of tyramine. I've mentioned red wine, cheese, smoked meat, and all that. These have high levels of tyramine. When you take it with agents that inhibit monoamine oxidase A, monoamine oxidase A is supposed to metabolize tyramine. So if monoamine oxidase A is inhibited, what it means is tyramine will accumulate in the body. And once tyramine accumulates in the body, it will precipitate hypertensive crisis. And that is what we call the cheese reaction. So that reaction where you have high levels of tyramine not being metabolized because you've taken a drug that has inhibited monoamine oxidase A. So basically that's the cheese reaction. And I'm saying for selective monoamine oxidase B, like the salicylic rasagiline, they have no effect on monoamine oxidase A. So when you take red wine, you take this medication with the foods I've mentioned, you shouldn't have cheese reaction at the normal therapeutic dose, which is used in Parkinson's disease. But at very high doses, these agents tend to lose selectivity. They may inhibit monoamine oxidase A. Once monoamine oxidase A is inhibited and you take cheese, you take red wine, you take smoked meat with these drugs, then you can have that hypertensive crisis occurring. And this is only occurring when you have salicylic at high doses, but at the normal doses, you shouldn't have it.
Dr. Ishak. Hello.
Hello.
Hello, Dr. Ishak.
Yeah, I'm listening.
Yes, so I'm saying that so for the selective ones, do we necessarily need to advise them to take it? It's just that it wouldn't have any effect. But then even at high doses, then there can be that problem. So I'm just wondering why we have to advise them to take it with it.
I didn't say we should advise them. I'm just telling you what the cheese reaction is about. So the advice is not to take it with red wine, take it with cheese, take it with smoked meat. That's not the advice. That advice is given when you are taking non-selective monoamine inhibitors. An example is phenelzine. So if you put a patient on phenelzine, it's a strict advice. Do not take tyramine-rich foods, and you give them examples. But salicylic, that advice is not needed because you are giving them a certain dose that wouldn't cause. Is it clear?
Yes, please.
Okay. Any other question? All right. Let's move on to talk about the next class of antiparkinsonians. So the anticholinergics. So basically, these anticholinergics are also used as adjuncts to the main therapy. For the anticholinergics, when we say cholinergic, we are talking about muscarinic and nicotinic. So the muscarinic receptors, the nicotinic receptors. Here, the issue is because of high levels of acetylcholine. So in the brain, there is a balance between acetylcholine and dopamine. They tend to check each other. So it's more like an equilibrium levels of dopamine and acetylcholine. So what happens is that if you have Parkinson's disease where there is loss of dopaminergic neurons, it means that you have low levels of dopamine. And if you have low levels of dopamine, that low levels cannot check the effect of acetylcholine. So you have this upregulated acetylcholine levels. And these upregulated acetylcholine levels tend to mediate some of the extrapyramidal signs and symptoms we see, like the tremors especially. And because of that, you need to control the levels of acetylcholine. So all the drugs that we've been talking about, you realize that Their purpose is they want to increase the levels of dopamine. So dopamine agonist.
Hi.
Hello.
Yes, sir.
Hello, sir.
Hello. Yeah. All right. So sorry about that. I was talking about the anticholinergics. So basically, I said we have um, levels of acetylcholine being upregulated because in Parkinson's disease, there's loss of dopaminergic neurons. And if you have loss of dopaminergic neurons, it translates to low levels of dopamine. And that low levels of dopamine is not enough to check the levels of acetylcholine. So there's upregulation of acetylcholine, and acetylcholine mediates the extrapyramidal signs and symptoms like the tremors. So because of that, you want to control the levels of acetylcholine. And to do that, you need anticholinergics. So you know acetylcholine binds to the receptors muscarinic, nicotinics. So we are giving anticholinergics to block these receptors. By blocking the receptors, it's preventing acetylcholine from binding to these receptors to cause the tremors that we see in Parkinson's. So for anticholinergics, their main use is for tremor-dominant Parkinson's disease. So if the person has Parkinson's disease, but in terms of the clinical manifestation, the dominant clinical manifestation is tremors, then you want to introduce anticholinergic. So we use it in tremor-dominant Parkinson's disease. And examples of these anticholinergics, we have benztropine. So benztropine, you know the common brand name of benztropine is Cogentin. So benztropine, I'll type it in the chat box so that you see. So benztropine, common brand name, Cogentin. Then we also have trihexyphenidyl. Trihexyphenidyl. And that one, the common brand name is Attain. So Attain or benzhizol. Benzhizol. Then you could also have another agent known as procyclidine. So all these are anticholinergics that we can use. Benztropine, trihexyphenidyl, procyclidine. So their main use is to control the tremors by inhibiting the receptor for acetylcholine. In terms of, there are a lot of anticholinergics, but we are using these agents because these are centrally acting anticholinergics. So we are not using the atropine, buscopan, oxybutynin. All these are anticholinergics, but we are using the ones that are centrally acting. So that's why we are doing benztropine, trihexyphenidyl. All right. The issues with these, anticholinergics tend to do the opposite of sludge. Sludge, salivation, lacrimation, urination, diarrhea, GI distress, emesis. So they tend to do the opposite of sludge. So instead of salivation, the side effects will be dry mouth, lacrimation, dry eyes, urination, urine retention, diarrhea, constipation. So these are some of the common side effects we expect to see with the anticholinergics. Then, in the elderly, you usually want to avoid anticholinergics in the elderly. For the elderly, they are usually prone to urine retention. So the patient may be having BPH and all that. So they are prone to urine retention. Remember when we're doing BPH, even before you put the patient on anticholinergic, you want to find out the post-voidal residual volume before you put the patient on anticholinergic because of the risk of urine retention associated with this population. We usually avoid it in the elderly patients. Any questions? Okay. Let's look at the next drug, apomorphine. So apomorphine is also a dopamine agonist. Just that for apomorphine, it comes in the form of an injectable preparation. So you give it as a subcutaneous injection. So it's also a dopamine agonist given as a subcutaneous injection. The main role of apomorphine is as a rescue agent when you have the off phenomenon of levodopa. So we use it as a rescue agent when you have off phenomenon of levodopa. I didn't talk about this. We have on and off effects of levodopa. So when we say on effect is the time that you've taken the drug and you are getting relief in the signs and symptoms. So during the on effect of levodopa, you wouldn't see the signs and symptoms of the Parkinson's disease. But with time, the drug will be wearing off. So you have the levels decreasing and the signs and symptoms start to return. So when the signs and symptoms like the tremors, rigidity, bradykinesia start to return whilst taking levodopa, then we say you have off phenomenon of levodopa. So it's like a switch. The on effect, you wouldn't see the signs and symptoms. The off effect, that's where you start seeing the signs and symptoms whilst on the levodopa. And this can be so severe that I told you about the motor dyskinesias. They can be so severe that you can have what we call akinesia. Akinesia is like freezing episode. So, Parkinson's disease causes bradykinesia, slow movement. So the movement can be so much slow that it gets to a point in time you are freezing. You are not able to move at all. So that's akinesia. At that point, you need something emergency. So you need to give something injectable. So this is where apomorphine comes in. So apomorphine is given as a subcutaneous injection, a continuous subcutaneous injection. And the main reason we are giving is as a rescue therapy when you have akinetic movements. So when you have akinetic movements from levodopa, then you can give apomorphine. So that's the main purpose of apomorphine. They are usually
Dr.
used
Shak,
the last line. Hello?
Dr. Shak, please, is this with the off phenomenon you just explained? Is this what occurs in stiff person syndrome?
You said, does it occur in?
We spoke about akinesia in Parkinson's disease during the off phenomenon. So I want to find out, is this what occurs in stiff person syndrome, or that is completely different?
No, that's completely different. This one, the akinesia, is because of levodopa. So the levodopa that you've taken can cause some side effects. And these are motor dyskinesias. So that you can have these abnormal movements. And one of them is akinesia. So akinesia, they are freezing episodes. Stiff person syndrome is an autoimmune condition that can also present as such, but that you can have spasms and all that. So it's different.
Also, I want to find out. Initially, you spoke about Parkinsonism and Parkinson's. So these drugs we've treated so far, are they also used in the management of Parkinsonism, or something else is used in Parkinsonism?
Parkinsonism, the main thing is the underlying cause. So you treat the underlying cause. So if you have a stroke affecting the basal ganglia, so an infarct or a bleed in the basal ganglia, the basal ganglia is the portion that controls the movements. That's where you have the substantia nigra. So you may have this Parkinson-like symptoms. They usually wouldn't respond to medications like the Cinemet, the Madopa. They wouldn't respond. The main thing is to treat the underlying cause. So stroke, ischemic stroke, your aspirin, your atorvastatin, your hemorrhagic stroke, your BP management, your ICP control. If it's drug-induced, metoclopramide, antipsychotic, when you withdraw the medication, the signs and symptoms tend to also resolve. If it's electrolyte imbalance like hypocalcemia, that can cause tremors and all that, you correct hypocalcemia and it resolves. If it's CNS infection, you give your antibiotics. If it's traumatic brain injury, you manage as such. So for Parkinsonism, you manage the underlying cause. But Parkinson's disease, you don't know the cause.
Yes, please. Thank you.
And Doc, please, do you mind going over the off and on phenomenon again, please?
So the on phenomenon is whilst you're on the medication and you are getting relief of symptoms. So we say you're experiencing the on effect of the drug. So you are not showing any symptoms whilst on the medication. But you can still be on levodopa and show these signs and symptoms, the tremors, the rigidity. So that's what we call the off effect. So the off effect, whilst on the medication, you are showing signs and symptoms of the Parkinson's. So this is where the apomorphine comes in. So it's supposed to manage the off effect of levodopa. So where you have the signs and symptoms, that's whilst on the levodopa, you can give the apomorphine. Any other question? Okay. So for the apomorphine, what we are usually concerned about is the side effects. They tend to cause severe vomiting. So there's severe emesis associated with apomorphine. So before you even start apomorphine, you have to start an antiemetic as a pre-medication. So 3 days before starting apomorphine, you should start antiemetic. So if you want to start apomorphine on maybe Thursday, you should have started your antiemetic like Monday. So 3 days before the start of apomorphine, you do your antiemetics and you continue whilst the patient is on it. So which antiemetic would you want to give? Any ideas? Which antiemetic can be given? Yeah, so you can do domperidone. Can we do metoclopramide?
No, sir.
Any reason? Because metoclopramide and domperidone, they belong to the same class. So they are both dopamine antagonists and they are prokinetics. So why would you want to do domperidone but not metoclopramide?
It's because the metoclopramide can cross the BBB.
Yeah, so metoclopramide and domperidone are both dopamine antagonists. But the difference is that metoclopramide blocks dopamine receptors in the brain and also in the periphery, whereas domperidone only blocks dopamine receptors in the periphery. So metoclopramide blocks central and peripheral dopamine receptors, whereas domperidone blocks the peripheral dopamine receptors. So Parkinson's disease, we need high levels of dopamine. So anything blocking the dopamine receptors is going to affect or worsen the signs and symptoms. So metoclopramide should be avoided because it will block the central dopamine receptors and that will worsen Parkinson's. But domperidone wouldn't worsen Parkinson's because it has no effect central. Its effect is the periphery. So you can give metoclopramide. Can we give promethazine? Can we give promethazine as an antiemetic? So you avoid promethazine too. So promethazine belongs to the phenothiazine class. And you know the phenothiazines are also antipsychotics, first generation antipsychotics. You know the common side effects with first generation antipsychotics. So they block dopamine receptors and they can cause extrapyramidal side effects. Whilst the second generation tend to cause metabolic side effects. First generation, more extrapyramidal. So promethazine, we can't give promethazine to as well. So domperidone is the preferred. The other class of antiemetics, like the 5-HT3 receptor blockers. So you know the 5-HT3 receptor blockers, they are usually used in chemotherapy-induced nausea vomiting. So ondansetron, granisetron. These agents can be used for nausea and vomiting associated with other anti-Parkinsonian drugs. So maybe if you have Cinemet causing nausea and vomiting, you can take your ondansetron or granisetron. However, if the patient is on apomorphine and is having nausea and vomiting, you avoid 5-HT3 receptor blockers. And this is because they can cause a sudden loss of consciousness. They can also cause hypotension and sudden death. So because of that, you avoid 5-HT3 receptor blockers if the patient is on apomorphine. The sudden loss of consciousness, you could also have hypotension, and you could also have death. Aside the nausea and vomiting side effect, one of the common side effects of apomorphine is yawning. So the patient will be yawning a lot if the patient is put on apomorphine. So you should also look out for that. And it can also cause dizziness, QT prolongation. All these are side effects of apomorphine. Any questions on apomorphine? All right, let's look at the last drug. So the last drug is the antivirals. So the antiviral here we use is amantadine. So I may ask, why are you using antiviral in Parkinson's disease, which is not caused by a virus? So amantadine, the main indication for amantadine is influenza. So influenza, that's where you use amantadine, zanamivir, or oseltamivir. These are antivirals for influenza. So that is where amantadine falls. But it has additional benefit. That is why it's employed in Parkinson's disease. So the benefit is that amantadine is able to inhibit the reuptake of dopamine in the presynaptic neurons. So they block the reuptake of dopamine in the presynaptic neurons. And that increases the levels of dopamine in the presynaptic area. So anything that's increasing the available levels of dopamine is going to help reduce the signs and symptoms. So this inhibits the reuptake of dopamine at the presynaptic neurons, thereby increasing the levels of dopamine at the presynaptic fibers. So for amantadine, it's also used as an adjunct to the main therapy. It's not used as a standalone, usually as an adjunct. And it's also beneficial when you have off phenomenon of levodopa. So when you have the off effect of levodopa, you can introduce amantadine. So the dose is usually 100 milligram BD or TDS. That's usually the dose. The common side effects you should look out for with amantadine. You may have hallucinations. So hallucinations, abnormal dreams. So you may be dreaming about abnormal things. You may also have dizziness and also insomnia. So you can have dizziness, insomnia, abnormal dreams, hallucinations. There's also another skin condition that is associated with amantadine, which is known as libido reticularis. So I'll type it in the chat box. So libido reticularis. So libido reticularis, usually you see this reddish skin appearance. So there's this reddish skin appearance. We usually call it the mottled skin. So mottled skin. You can check pictures of it. Once you have this side effect, you have to discontinue the drug. So amantadine can do libido reticularis, which is known as the mottled skin. Any questions? I think that's the last drug for the anti-Parkinson. All right. If there are no questions, I think I'll send you some questions. Then we discuss the questions. So that hopefully on Thursday, we wrap up with the PSGs.
Dr. Isha.
Yeah. So Matthias, I've sent you the questions.
Please, would we do the schizophrenia and the rest, like bipolar or depression?
No, we wouldn't do it. You can read on those topics. Those are miscellaneous areas. They are not key areas. So you usually don't have a lot of questions on it. But what I would advise is that you can just read on the common medications that are used. So you know that schizophrenia, we use antipsychotics. So you should know examples under first generation antipsychotics, second generation, common side effects you expect with first generation, second generation. Then some common drugs that are used. So something small about haloperidol, olanzapine, risperidone, you can read, but it's not one of the key areas. Then so bipolar 2, the same thing. You can read on the medications that are used. Matthias, you have the questions. Have you sent it to them?
Yes, please.
Okay. So let's go through the questions. You can share the screen and we'll go through the questions. All right. Who is reading for us?
I'll read, sir.
Okay.
So, question 1. Pale rolling tremors is a characteristic action tremor seen in patients with Parkinson disease. True or false?
Okay. So is it a true or false statement?
True. A.
Okay, so I'm hearing true, I'm hearing false. So which is which?
False.
So those going for true, different, false, different.
We said that the pill rolling tremor is a characteristic of resting tremors, not the action tremor.
Yeah, so even though you have pure rolling tremors in Parkinson's, but it's not an action tremor, it's rather a resting tremor. Okay, let's move on.
Question 2. Which of the following features is the least Which of the following features is the least disabling manifestation of Parkinson disease? A. Postural instability. B. Tremors. C. Rigidity. D. Bradykinesia.
Okay, so which of them causes the least disabling effect?
Tremor.
Yeah, it's tremors. So tremors causes the least form of disability. So if a Parkinson's disease person has tremor, you may not even notice. They'll go about their everyday activity, you wouldn't notice. It's only when they're at rest that you may start seeing the tremors. But everything, in terms of activity, you wouldn't see. So it's the least disabling. Let's move on.
Question 3. Question 3. What is the frequency of tremors seen in Parkinson disease? A. 3 to 7 hertz. B. 20 to 25 hertz. C. 10 to 15 hertz. D. 12 to 20 hertz.
Yeah, so what's the frequency of the tremors? Anyone trying? So I didn't mention it, right? So the frequency is usually 3 to 7 hertz. So 3 to 7 hertz. But most patients will have between 4 to 6 hertz. So the range is 3 to 7 hertz. But most patients will have 4 to 6 hertz. Okay, let's move on.
Question 4. Major cause of disability in Parkinson disease patients is A. Resting tremors. B. Postural instability. C. Bradykinesia. D. Rigidity.
All right, so which of them causes the most disability?
Rigidity.
Which of them? Anyone trying? So it's the bradykinesia. So bradykinesia causes the major disability. So there's that slowness in movement. It can progress to stages where there's even freezing episodes. So imagine you are crossing the road and there's that bradykinesia, slow movement. There's risk of you being knocked down by cars. You are likely to fall and all that. So it causes the most disability. So patient may even, because of the slow movements, they are usually stationary or they are bedridden. They don't go anywhere. Okay, let's move on.
Sir,
Question.
sir, please, people in general, can you say that it's also due to these loss of neurons, but not as severe to cause the Parkinson's disease? That's why they mostly have this slow movement.
I didn't get your question.
Okay, sir, so mostly old people, they have this like slow way of walking and doing their stuff. So I was wondering if that could also be related to, let's say, a loss of some of these neurons, but not like that severe to classify it as like a disease.
Yeah, so generally, in terms of strength, old people tend to have reduced strength. Everything is reduced. It's because of they've lost a lot of neurons, age-related loss of neurons. So it may not necessarily be Parkinson's disease, but their movement is generally slow.
Yeah, so can it also be due to the osteoarthritis and the rest?
Yeah. So they may have a lot of comorbid conditions. So it may not even be that they have slow movement, but because they are experiencing pain at their joints, so they tend to move at a very slow pace because of the pain they experience when they walk. So you always have to factor in a lot of things before you say they actually have bradykinesia. Let's move on.
Question 5. Characteristic pattern of resistance and relaxation as the examiner moves the patient limb through its full range of motion is termed characteristic ratchet pattern of resistance and relaxation as the examiner moves the patient limb through its full range of motion is termed A. Pale rolling rigidity. B. Cogwheel rigidity. C. Lead pipe rigidity. D. Glabellar rigidity.
Okay, so which one are you going for?
Cogwheel rigid.
So cogwheel rigidity. You have that ratchet pattern of resistance and relaxation.
Question 6. Dopamine agonists have more motor complications than levodopa. True or false?
Okay, so true or false?
False.
So it's false, right? The dopamine agonists
Yes,
tend to
please.
have more impulse control disorders, while the levodopa tend to cause motor complications, the dyskinesias. All right, so let's move on.
Question 7. All the following
So,
are
can
selective.
you repeat what he said?
I was saying dopamine agonists cause more impulse control disorders. Levodopa, more motor complications. Let's move on.
Question 7. Question 7. All the following are selective monoamine oxidase B inhibitors except A. Salicylic, B. Phenelzine, C. Razagelin, D. Safinamide.
Okay, so which of them?
Phenelzine.
Yeah, so phenolphthalein. So that's non-selective. Okay.
Question 8. You received a prescription of salicylic 5 mg BD for 30 days. At what times would you counsel the patient to take the medication? A. 8 a.m. and 8 p.m. D. 6 a.m. and 6 p.m. C. 6 a.m. and 12 p.m. D. 8 a.m. and 4 p.m. C.
So which one are you going for?
C.
C.
Yeah, so C, 6 a.m., 12 p.m. Let's move on.
Question 9. Which of these antivirals is indicated in Parkinson's disease? A. Remdesivir. B. Tamiflu. C. Zanamivir. D. Amantadine. Is D.
D.
Yeah, so amantadine. Amantadine. Remdesivir is COVID. Zanamivir, Tamiflu, influenza. Okay.
Question 10. Which of the following anticholinergics is not used in Parkinson's disease? A. Cogentin. B. Benzizole. C. Procyclidine. D. Hyoscine butabromide.
All right,
D.
which of them? Yeah, hyoscine butabromide.
Question 11. Which of these agents is used in a rescue therapy in Parkinson's patient experiencing sudden akinesia episode? Apomorphine. A. Pramipizole. B. Levodopa. C. Entacapone. D. Apomorphine.
So which of them?
D.
Yeah, so D, apomorphine.
Question 12. Which of the following dopamine agonists comes in form of transdermal patches? A. Pallodel. B. Rotigolin. No, rotigotine. C. Pramipizole. D. Ropinirole. Ropinirole.
Yeah, so which of them comes in the form of transdermal patch?
Matthias to relax.
B.
Yeah, so rotigotine. Rotigotine. Pallodel is the brand name for cabergoline. No, Pallodel is the brand name for bromocriptine. Bromocriptine. Dostines is cabergoline. All right, let's move on.
Question 13. Compulsive sexual behavior, pathological gambling, and compulsive buying associated with anti-Parkinsonian drugs is termed A. Bulimia nervosa. B. On and off phenomenon. C. Impulse control disorders. D. End of dose deterioration. C.
C.
Yeah, so C, impulse control disorders.
Question 14. Dopamine agonists are more likely to cause impulse control disorders than levodopa. True or false?
True or false?
True.
Yeah, so that's a true statement. Let's
Question
move on.
15. Non-ergot derived dopamine agonists have limited role in Parkinson's disease because of risks of valvular heart disease, cardiac and pulmonary fibrosis. True or false?
False.
So true or false?
False.
Okay, so it's false. It's rather the ergot derived, not the non-ergot derived.
Question 16. All the following side effects of levodopa can be reduced when combined with carbidopa, except A. Nausea, B. Hallucination, C. Vomiting, D. Orthostatic hypotension.
Okay, so which of them?
Hallucination.
Yeah, hallucinations. Yeah.
B. Mm. Question 17. Operibia, a 78-year-old patient with Parkinson's disease presents to you with complaints of nausea and vomiting. Which of the following antiemetics can be given? A. Metoclopramide. B. Trimethopenzamide. C. Avomine. D. Stemetel.
Okay,
C.
so which one?
C.
B.
So I'm hearing C, I'm hearing B. So which is which?
B.
Avomine
So it's
is
B, right?
B.
So it's B. Avomine is what? Promethazine. What about stemetel? What's the active ingredients of stemetel? And so that prochlorperazine. So prochlorperazine can also not be used. Cannot be used because of the fact that it also blocks dopamine. As part of the antipsychotics, blocks dopamine. So we can't use stemetel, but we can use trimethopenzamide. Let's move on.
Question 8. Total daily amount of carbidopa needed to effectively inhibit peripheral conversion of levodopa is A. 25 to 50 milligram. B. 100 to 250 milligram. C. 70 to 100 milligram. D. 125 to 250 milligram. C.
So which of them?
C.
Yes, so 70 to 100.
Question 19. Which of these antipsychotics should be avoided in managing psychosis in a patient with Parkinson's disease? A. Quetiapine. B. Pimavanserin. C. Clozapine. D. Risperidone.
All right, so which one should be avoided? And there's a dicey situation because Parkinson's, the issue is low levels of dopamine. For you to have psychosis is one of the non-motor manifestations of Parkinson's disease. Aside that, the drugs that you are using to treat Parkinson's, dopamine agonists, levodopa, they are going to increase the levels of dopamine in the brain. And whenever the levels of dopamine increases in the brain, it can lead to psychosis. When the levels are low, it can lead to Parkinson's. So it is a dicey situation. Now you have psychosis in Parkinson's. So how do you manage? Because in psychosis, you use antipsychotics. And these are dopamine receptor blockers. So the antipsychotics you are going to use can worsen Parkinson's. So in terms of the antipsychotics, which ones are safer to use when you have Parkinson's disease and which one should you avoid? So first question, which one should be avoided? So there are three antipsychotics that have been shown to be relatively safe compared to the others. So we can use quetiapine to manage the psychosis. You can use pimavanserin. You can use clozapine. But you can't use risperidone, you can't use haloperidol, aripiprazole, the other antipsychotics you can't use. The three safe ones are quetiapine, clozapine, and pimavanserin. All right, let's move on.
Question 20. Entacapone is usually associated with hepatotoxicity compared to salcapone. True or false?
So true or false?
False.
Yeah, so it's false. We said salcapone is associated with more hepatotoxicity. Okay.
Question 21. Salcapone is more effective as catecholamine or methyltransferase inhibitor than entacapone and opicapone. True or false?
True.
True.
Yeah, so that's a true statement.
Question 22. Cheese reaction is a common side effect of selegiline taken at normal recommended dose for Parkinson's disease. True or false? False.
False.
Yeah, so there's a false statement.
Question 23. High protein diet should be avoided in patients taking A. Tolcapone, B. Levodopa, C. Amantadine, D. Pramiprazole.
So which of them?
Levodopa.
Yeah, so levodopa.
Levodopa, question 24. Levodopa and all the catecholamine or methyltransferase inhibitors can cause urine discoloration. True or false?
False.
Yeah, so that's a false statement.
Question 25. Ondansetron can be used as an antiemetic for all the following antiparkinsonian drugs except A. Opinrol, B. Levodopa benzrazide, C. Apomorphine, D. Amantadine.
C.
C.
Hello? Hello?
Hello.
Is Dr. Ishak still there?
Hello?
Hello?
Yeah, so then the last question, the answer is what?
C.
Yeah, so C, apomorphine. That's the last question, right? Or we have more?
Question 26.
Okay.
Question 26. Which of the following anti-Parkinsonian drug requires a 3-day prior pre-medication with an anti-emetic before its use? Apomorphine.
Apomorphine. Okay. That's the last question, right?
Yes, please.
Okay. All right. We'll end here. Hopefully, Thursday, maybe we may meet and finish up with the PhDs. Our next clinical topic will be stroke. So we'll read on stroke so that the next time we meet, we'll go through. If there is no question, then we end here. Have a good morning.
You too.